Beyond the Plate, what you need to know.
Did you know that diet is not the only thing that we must consider when living a healthy lifestyle if we have diabetes? Welcome to Health IQ Podcast. I'm Brenda Bishop, your host, and joining me at the table today is Lindsy Foust with the Presbyterian Medical Group here in Tucumcari. And we're going to be visiting about all those other things we need to think about today if we have diabetes so that we stay healthy and able to do all the things we want to do. So thank you, Lindsy, for joining us.
Thanks for having me.
I think we'll just jump right in with the importance of going to see your provider. I think it's every 3 months.
Correct. And so if you've been diagnosed with diabetes, you should be having a follow-up with your PCP, whether your primary care provider or your endocrinologist, at least every 3 to 6 months, depending on how well controlled your diabetes is. And so that's a really good place to start.
Yes. And you were telling me earlier you have like a diabetes bundle of things you do to make sure.
That's correct. So we have what we call a D6 criteria, and it monitors for several important things that we need to be making sure our diabetic patients are adhering to or trying to meet goals. And so when you guys asked me to speak on this podcast today, I thought that's a really great starting place so that diabetic patients can know how they can best help their diabetes and help prevent long-term complications. Because as we were talking about earlier, there's different areas that we don't always think about that our diabetes will affect. And so I'll get started with that. So those 6 criteria that we look at, one is the A1C. We want to have a goal A1C of less than 8. Ideally, if we can get that a little bit tighter, less than 7 is even better. And we'll kind of get into why that's important here in just a minute, but that affects a lot of our other home care things that we can be doing. 2 is blood pressure. We need to make sure we have our blood pressure very well controlled. Depending on what criteria you look at, some will say less than 140 systolically, which is that top number. Some guidelines will say less than 130 systolically on that top number, but really trying to make sure we're somewhere within that goal range. Also on our D6 criteria is our GFR. That's our glomerular filtration rate, looking at how well our kidneys are functioning. Microalbumin is also a measurement of our kidney function. It will look at if our kidneys are spilling any protein into the urine. And again, in a minute, I'll kind of get to the why we're wanting to check these things. The other thing, eye exam. We need to be making sure we're having our eyes checked at least once a year. And then diabetic foot checks. We need to be doing that at least every 6 months. And so before you ask me any additional questions, let me just kind of get into the why, kind of behind why we do this. As most people know, diabetes, you have high glucose levels in your sugar or in your blood. So your sugars are elevated in the blood. So your blood's thicker. And if you think about how our blood is our main nutrient source of energy throughout the body, it flows to all of those vital organs. And so if that blood's running thicker, it's not getting to those vital organs quite as efficiently. So we're not getting oxygen, we're not offloading nutrients, we're not offloading waste products to get rid of from the body quite as easily. And then over the long run, we get damage to those organs. And it's what we call end organ damage. And so if you think about those organs that have the very small vasculature to them that we're most concerned with, the eyes, the kidneys, the heart, and then, of course, our skin tissue. If we get wounds or sores, they don't heal quite as effectively with diabetes.
That's right.
And
then, of course, if it would be probably just like is it where you get the tingling in your fingers or your toes?
Neuropathy.
They're furthest away from your heart and your source of nutrients, or oxygen. So, yes, it all makes sense that we need to be thinking about all of our organs, not just the diet in our stomach.
And then kind of to touch, kind of going back into breaking up those 6 criteria, kind of starting with the A1C. I think a good starting point for diabetic patients, if you're newly diagnosed or if you've been a diabetic for a long time, Something that a lot of patients aren't aware of is that if you're on insulin therapy, your insurance most likely will cover a continuous glucose monitor. And so if you haven't looked into that, I encourage patients to look into that, because that continuous glucose monitor, it's a patch you wear on the back of your arm. You have a device, whether it's on your phone or a glucometer device. You don't have to do the finger pokes. And that way you can monitor your glucose more frequently and learn to get tighter control of your glucose that way. Other home care instructions in terms of that A1C, monitoring for hypoglycemic episodes. So if our sugars start to drop too low at home, making sure, and your PCP or endocrinologist should give you these parameters as well, that if your sugars drop too low, and what is too low? If you're dropping below 80 on your glucose, you're starting to feel weak, shaky, lightheaded, dizzy. Check your sugars. If you have a continuous glucose monitor, it should alert you if you're dropping low. And then you're going to want to consume something sweet. So an 8-ounce glass of orange juice or an 8-ounce glass of soda. I know we don't usually say drink soda, but that's something that will boost the sugars quickly.
So the challenge with that is a lot of times when we make these big diet changes, those are like the kinds of things we get rid of in our homes. So, they even have glucose tabs that you can keep on hand or something like that if you don't have juice or something available.
And the other thing is, if you are having reoccurrent hypoglycemic episodes, that's an indication your medications aren't well adjusted, and so you need to follow up with your PCP, even if it's sooner than that 3-month time frame. Follow up sooner so we can make adjustments to medications. And then kind of going on to the next criterion, our D6, the blood pressure control. You mentioned, there's more than just diabetic or dietary modifications that we can make. And one of those is physical activity. And guidelines recommend 150 minutes of moderate physical activity a week. And I'll have patients who will tell me, well, I stand all day at work, or, I'm moving all day at work. And so they count that as their moderate physical activity. But I tell my patients, moderate physical activity gets your resting heart rate elevated. And ideally, we want to elevate it kind of in that 115, 120 range. And so most patients or most people these days have smartwatches that can monitor that heart rate. And so I tell them, find something that you enjoy doing, whether it's going for a brisk walk, on your bicycle, on an elliptical, if you have a home, machine, workout equipment, find something that you enjoy doing that will be sustainable, and then try to get to 150 minutes a week of that moderate physical activity. That will help with your A1C control. That will help with blood pressure control. We'll talk about it here in a little bit, but your lipid control, your LDL, cholesterol, it'll help control that. And when we say 150 minutes a week, sometimes people are like, wow, that's a lot of minutes.
Does sound like a lot.
You can break it down into 30 to 40 minutes, 4 to 5 days of the week. So it doesn't even have to be every single day. And it's not something that if you have been sedentary and you haven't been incorporating any exercise into your regular routine, you're not going to start out and, on your first day and do 40 minutes of moderate physical activity. You'll probably start with 5 or 10 minutes of activity. Kind of listen to your body. If your body says that's enough, you'll back off. And, the next day or the next week, you work up a little bit by 5 or 10 minutes and eventually work your way to that goal of 150 minutes a week. In addition to moderate physical activity, you want to also consider strength training 2 days of the week. So something that helps strengthen the muscles, whether it's, 5-pound arm dumbbell weights that when you go for your brisk walk, you're walking with those dumbbells, or other forms of strength training is recommended as well. So
I read something about one of the best things you could do is a farmer's carry, they call it, where you put just heavy weight in both hands and walk. So that would feel right with that.
They also make weights that you can strap to your wrist or strap to your ankles, and those are good weight-resistant training as well. So lots of things that you can consider to get to that level of activity. But it's more than just being having a lot of movement in your day-to-day, this is set aside time that needs to be intentional with moderate physical activity.
Okay, and that would help us get our blood pressure down, which is important, and possibly lose a little weight, which is also would help with blood pressure.
As well as A1C control. We mentioned it could also help with the LDL levels, which is the bad cholesterol. So on our D6 criteria, we check these. Sometimes they're every 6 months, maybe every 12 months, depending on how controlled you are. But that LDL level, we really want to be below 100. And the reason behind that is if you think about your thick, sugary blood flowing through your system, if you add fatty blood to that because of a high lipid panel or high lipids in your blood, that makes your blood even more thick. And so it's kind of a double whammy to these end organs that we're talking about. And so, again, the moderate physical activity can really help improve your lipid panel, the LDL. Mediterranean type lifestyle, whole grains, fresh fruits and vegetables, good source of omega-3 fatty acids, which are anti-inflammatory. But I know we won't go too much into diet for this podcast. Right. And the other thing I want to touch on is statin therapy. I know there's a lot of hesitation around statins. Some patients do have adverse reactions to statins. It builds up into their muscles, makes their muscles kind of achy. But guidelines recommend anybody who's been diagnosed with diabetes start on a statin medication if they can tolerate it. Because one, it stabilizes the plaque buildup. So the plaque that's already built up in those vessels where that thick blood's running through, it stabilizes that to where they're less likely to break off and cause heart attack or stroke. And then it also reduces that LDL level to where it's less likely to build up and cause additional problems.
Okay.
And so if you haven't talked to your PCP about that, that's something I would encourage you to ask about.
Well, and I was thinking back to one of a previous podcast where they were talking about the importance of fiber and all those things you mentioned. Is that fiber that would help lower that LDL too? So,
yep, that's absolutely.
Yeah, check it back into some of our older episodes. We have some great stuff on diabetic diets. And then, so you've had LDL, and then you talked about the eye exam that you guys, and you offer a special eye exam for people with diabetes.
We do. So at Presbyterian Medical Group, we have a Retina View eye machine, which will look at the vessels behind the eye because that's what we're worried about with diabetes. Again, if that blood flow to the eye is real thick, it doesn't perfuse those arteries quite as well. And so we can end up with eye disease, eye damage, retinopathy, where diabetic patients are at increased risk of losing their vision. And if we can detect that early, then the outcome's much better in preventing complete vision loss from the diabetes. And so I encourage you, that needs to be done at least once a year with the diabetic eye checks. If you have an eye doctor that you see on a regular basis, they should be doing those diabetic eye checks as well. But again, it needs to be done once a year.
And I think you talked about foot care.
Yep. The other thing, diabetic foot exams, we need to be doing that at least every 6 months. And actually patients can do their own diabetic foot checks daily. So when you go to put on your socks, when you put on your shoes, you need to be checking the bottom of your feet, the sides of your feet for any sores, lesions, calluses, anything that can turn into a wound, blisters. Because diabetic wounds can get progressively worse and to the point where we may have to consider amputation if it gets to that point. And so, the earlier we can catch that, the better. But if we can have our A1C under control, our blood pressure under control, better lipid profile, those risk of complications go down considerably.
And so what's involved in that diabetic foot check with you all? Is it more than just a visual check?
Yeah. So we check pulses, we check for wounds, we check sensation. We use a microfilament to check that sensation. As you were talking about earlier, the neuropathy that diabetic patients can develop. most often affects the feet first, although we can develop that other places as well. But usually it's the feet that most diabetic patients develop first. And that neuropathy leads to, you don't have that sensation of, oh, ouch, I have a wound, or I, stepped on a sticker and got a splinter, and then that splinter festers into a wound. Diabetic patients don't quite have that sensation. And so, again, they're increased risk of developing complications. The other thing, nail hygiene for diabetic patients. When we trim our toenails, as we get older, a lot of older patients can have fungal nail disease. Fungal nails are very thick and very hard to treat. They're very hard to care for. And so if you're a diabetic patient and you have fungal nail disease, what we recommend is that you see a podiatrist to trim those nails. We're not allowed in a primary care office to trim the nails because of the risk of complications with wounds. The wrong nick can create a wound. And so diabetic patients can see a podiatrist for that nail hygiene. And so we just recently, in the last 3 months or so, we've had a podiatrist who comes out of Clovis here to Dancy Trigg Clinic, and he'll see patients from all over. As long as your PCP has put in a referral for you to see the podiatrist, he'll get you on his schedule and he'll see you. And, if you have calluses that need to be taken care of, or if you have the nail hygiene that needs to be taken care of, he'll complete that.
So I'm hearing that cuts are a problem. And so you want to make sure you're not trimming your own, where you could accidentally cut yourself. And probably that goes with not going barefoot very much too, because
and that's a really good point. Yeah, making sure you have proper shoes, wide toe box. Shoes that aren't putting a lot of pressure on the foot, increasing the risk of a sore rubbing or developing. And then, like you said, a good sole base that we don't get puncture wounds into the base of the foot.
So I see things in my Facebook feed about diabetic socks. Is it important that they choose a better sock?
And with those diabetic socks, a lot of them have the compression stockings with them, so that helps improve that circulation. So kind of going back to when we have thick blood, that's kind of sluggish flowing through there. When we get the compression stockings on, that helps improve that circulation.
So you mentioned that wounds are hard to heal. Is there certain things that they should be doing to care for wounds or not doing to care for?
That's a good question. In school, they taught us if you can't put it in your eye, don't put it on a wound. And I think that's a really good advice. And so a lot of patients will tell me, well, I put rubbing alcohol on it. And it's like, well, would you pour rubbing alcohol in your eye? And so that actually kills some of the good bacteria that helps the wound heal. And so if you do have a diabetic wound, see your PCP, have them manage the wound, or refer you to a podiatrist for that wound management. And just be very cautious with what you are putting on that wound. Keeping it clean and dry, kind of the big mainstay treatment.
Okay. So probably changing whatever the bandage you're using pretty often.
Yeah, and that will be up to PCP and podiatrist discretion on what wound material they use to help that heal.
So let's see. We've talked how we covered all the details on all the different.
There was one more thing I wanted to talk about with the GFR, the glomerular filtration rate. Chronic kidney disease is very common with diabetic patients. Again, our kidney has lots of small vasculature. That thick blood that flows through the kidney doesn't perfuse the kidney quite as well, and so you need to be having your kidney function checked at least on blood work every 6 to 12 months. A microalbumin is a urine check, and that needs to be done at least once a year. Just kind of self-care that diabetic patients can do at home. One, make sure your kidney's hydrated. Minimum of 64 ounces of water a day, as long as you don't have any underlying other health conditions like heart failure. I typically recommend 64 ounces water a day. Again, if you think about your thick blood, if that blood's dehydrated because you're not drinking enough water, it's just going to make your blood more thick. And then again, 64 ounces of water will help perfuse the kidneys and keep the kidneys healthy. I tell my patients, for every cup of caffeinated beverage that you drink, because caffeine is a diuretic, you need to increase your water intake by a cup. And then if you have diabetes, it's also important that you're monitoring your NSAID use, so ibuprofen, Motrin, Aleve, other NSAIDs like Celebrex, Meloxicam, those are hard on the kidney. And so with your diabetes, you just got to be very cautious and make sure your kidney function's staying in a good range on these checks in order for you to continue on those medications. Something that oftentimes goes overlooked is our vitamin D. There are many studies that link vitamin D health to our kidney health. And so making sure you're getting good vitamin D. Baseline guidelines for our bone health recommend 800 to 1,000 IU of vitamin D a day. And then, of course, we need that sunshine to kind of help metabolize that vitamin D. But I do encourage, if you have a PCP endocrinologist, make sure that they're checking your vitamin D level as well.
I've had surgeons say that if your vitamin D is too low, they don't want to do the surgery because it won't heal.
It'll delay your healing process.
So I think they're finding more and more things that are important with vitamin D. Other professionals we should be seeing, we've talked about the podiatrist and the dentist.
So, and I start talking to my patients at a very young age, like even in my well child checks, the importance of going and seeing your dentist, every six months is what's recommended just for your dental hygiene. But there's more and more studies that are coming out that link inflammation in the gums and the teeth to chronic health conditions like diabetes and heart disease. And so if we can start at a young age of good oral hygiene, that can help prevent the development of some of these chronic conditions as we get older. Now, if you're a diabetic patient already who's, already got poor oral hygiene, I just encourage you, find a dentist and start getting those regular checkups.
Yes. And then we're getting close to time, but is there anything else on your notes that you wanted to make sure that we touched? And I was thinking about smoking and tobacco use.
I think that, in terms of anything in addition to smoking, that covers everything kind of on our D6 criteria that we monitor for. Of course, smoking, pro-inflammatory, that tobacco exposure, anything that's inflammatory is going to increase inflammation, increase complications with some of these chronic health conditions. Nicotine with smoking is also a vasoconstrictor, so it makes our vessels tighter. And so we've already talked about diabetic patients, your blood is thick already. If you have high lipid panels, it's even more thick. And then if you smoke, you're making those spaces much smaller for that blood to flow through. So it again, a triple whammy there with how well we're perfusing those end organs that often have consequences from the high blood sugars. So,
I was thinking as you were talking about that all relates to that wound care too, because smoking makes those vessels smaller and your wounds don't heal as well.
Because you're not delivering oxygen, you're not
Yes.
offloading the waste byproducts, and so definitely it delays wound healing.
So I want to thank you. This has been some very valuable information and probably important information for even people who don't have diabetes as far as the exercise and the smoking, the water, and maybe not all the exams, but if we can, like you say, learn to reduce that inflammation earlier. And we'd like to thank our crew today, Joyce Runyon and Bobby Hockaday, who are chasing something around the room. And thank you all for joining us today. And please come back in a couple of weeks as we will have another interesting health care topic.
Special thanks to our guest, Lindsy Foust, family nurse practitioner with Presbyterian Medical Group, and our host, Brenda Bishop, Quay County Health Council Coordinator.
Podcast crew, director, Robert F. Hockaday. Producers, Robert F. Hockaday, Joyce Runyon. Camera operator, Robert F. Hockaday. Second assistant operator, Joyce Runyon. Editor, Joyce Runyon. Music provided by David Morris. Funding for this podcast is provided by New Mexico Legislative Appropriation from Representative Jack Chatfield. Brought to you by Quay County Health Council. Follow us on YouTube, Facebook, and Instagram at Quay County Health. If you have content ideas, reach out to us at healthiqpodcast@gmail.com.
This podcast was created solely for educational and entertainment purposes. It is not intended as a substitute for advice from a healthcare or mental health professional.